Now, the organizers asked me to do two things, and the first thing they asked me to do was to say a little bit about my own journey and how I came to be here talking about this. And those of you who know me know that there's nothing I would like less than to do that, but I will compromise and say a little bit at least about the professional side of that journey, and if you would like to hear more about the personal side, you can come and find me later, and I'm not that well hidden. And professional side actually goes back to very early in my life, into my youth. Let's see. All right. You know, I was a math kid growing up and was always very, very intellectually curious. You know, I carried that sort of interest in mathematics through my youth into the early first phase of my career. And in parallel to that, my curiosity did lead me to explore psychedelics in what some outsiders might call recreationally, but for me was very much about intellectual development. And you know, that experience proved to be incredibly helpful for creativity, for problem solving, and even for insight and intuition about things like four-dimensional and five-dimensional objects that mathematicians, especially in the field of geometry, which I was in, need to work with. So I came and I brought some of that intuition and did some work while working at the University of Chicago. I'm still based in Chicago. But at a certain point, interest in that field tapped out, and I thought to myself, okay, what can I do professionally that is going to give me a wider aperture on what other kinds of interesting things are happening in the world? And so per what Kelsey said, I joined Boston Consulting Group, which is a premier consulting firm that works across many sectors, mostly with Fortune 100 companies on kind of once-in-a-career or very rare kinds of challenges that don't come up, that don't come up typically for executives there. And within a year or two of joining, I aligned myself with their healthcare practice. And I spent most of the next 20 years working with biopharma companies and med tech companies on the development of sort of innovation and commercial strategies for new offerings that do not fit cleanly into our healthcare system. And this idea about new offerings that don't fit cleanly into our healthcare system should ring a bell, of course, for this audience. And I had the amazing fortune on a really unforgettable day in the mid-2010s, my old friend from college, David Bronner, called me and said, "Hey, Dan, I'm on the board of this thing called MAPS, the Multidisciplinary Association of Psychedelic Studies. And they are working on getting MDMA to be approved as a prescription drug by the FDA. And I said, wait, say that one more time? And he said it again. And I said, wait, say it one more time. And then he started to convince me that it was real. And he said, but now they are at this amazing point where instead of just thinking about getting FDA approval, they're thinking about trying to commercialize it as a drug, to bring resources back into their broader mission for sort of, awareness and education and access to psychedelics. Problem is, he said, there's nobody who works there who has knowledge about how to commercialize a new drug. And then he said to me, so I raised my hand and said, oh, I know a guy at BCG who would like to help with that. And so that was me, and I had the incredible privilege of honor then of getting introduced to Rick, other leaders of MAPS, and getting more and more involved with the MAPS Public Benefit Corporation, now Lykos Therapeutics, of which I am on the board. I think I'm supposed to disclose that. I'm sorry I don't say it on a slide. And it's been an incredible privilege to get to work with and advise them. And as that became the most fulfilling part of my work with BCG, and as I approached my 20-year anniversary, I thought, okay, I've probably done all that I'm going to do within BCG. How else can I serve the psychedelic field? What other job will give me the widest aperture in terms of in what's happening in this field? And that turned out to involve joining a group called the Psychedelic Science Funders Collaborative, or PSFC. And PSFC had been an engine for, in a particular period of time, for philanthropic funding of MAPS and MAPS Public Benefit Corporation's work. And PSFC is a membership organization of about 100, I think we're north of 140 or so philanthropists who have significantly given to the psychedelic field and intend to continue doing so. And I now have the enormous privilege of working there and helping the members, helping these donors think ahead to what is actually going to be needed by the early 2030s in the psychedelic ecosystem to have the world we want, where people have risk-reduced and equitable access in a high-integrity way to psychedelics. And within that, what is the role of philanthropy to make that happen? So that's the work that I do today related to psychedelics. So that's a bit about the professional journey, and again, I'm happy to talk more about that privately. The second thing that the organizers asked me to do was to give a bit of the lay of the land. It cannot be to tell you everything that's going on in the industry landscape today. That couldn't be done in a full day, in a full week, certainly not in half an hour. But they did ask me to give some highlights in a way that will help set context for the other sessions that you will hear today, in a way that will feed questions that might at least get partially answered by other sessions today and over the next couple days of this conference. So That's what I'm going to try to do in a few parts. I'm going to talk a little bit about the latent demand and the flow of money. I'm going to talk a little bit about what patient journeys might look like. I'm going to talk a little bit about some of the challenges and dislocations we have today that business or that industry will need to solve, and then I'll hopefully leave you with a few questions that stick and can provide a frame of reference for other sessions that you'll be in. So I start looking at any industry in terms of what are the problems that industry is trying to solve, and how big are those problems? And it makes it a little crude, but say how big are those problems economically? And the psychedelics industry is not trying to solve one particular problem. It's hard to even wrap your arms around all that it could do. But if we take what is, at least conceptually, a very narrow slice, we can focus on mental health a little bit. And the value at stake in mental health, I probably don't need to tell you this, but it is really, really enormous. Forgive me, some of my slides are a little bit complicated and I try to jam too much in. Bear with me and I'll try to explain what each slide says and what's on each slide, and then I will say a little bit about what it means or why it's important. On this one, we're just looking at, for a couple of major mental health conditions, what is the annual economic burden of disease in the US? And so we've looked at 4 of them here: major depressive disorder, treatment-resistant depression, post-traumatic stress disorder, and alcohol use disorder. And I think for time, I'm not even going to break down all the pieces, but if you think about the total economic burden of major depressive disorder in the United States, comprising direct healthcare costs, unemployment costs, underemployment or productivity losses, and then other costs that come up, it's $325 billion per year that in some form or another, some participants in the US economy are losing due to the prevalence and severity of MDD. And if you add that up across these 4, you get to $850 billion per year. And this is 4 of many conditions for which psychedelics could be relevant. So it's very safe. And I would also say the authors of these papers, if you go and look them up, will acknowledge that their estimates are conservative in many places. So there's very little question that more than $1 trillion per year is lost to mental health conditions in the US for which there's some thesis that they might be partly amenable to treatment with psychedelic medicine. This says right away there is no problem with latent demand for a psychedelic industry to emerge. No problem with latent demand. Now that demand is only activated if you bring the right offerings to market in the ways that the entities bearing these costs will actually pay for and realize some benefit from. But in principle, there is enormous potential here, and there should not be a cap coming from demand. And of course, investors have started to recognize this and started to put some capital into the space in the hope of unlocking some of the revenue potential that this $850 billion implies. So now I'm going to show you an exhibit about the flow of capital into the psychedelic space and to various sectors, really over all time, but most of it is in the last several years. And I want to thank Psychedelic Alpha and Josh Hardman for furnishing this data and for making it very available to all of us. I don't know if anyone from Psychedelic Alpha is here, but it's really an invaluable source, so thanks to them. I'm going to walk you through this chart, and I apologize that some of the text labels are small, but I'll tell you what they say. This chart shows on the left side, we have where investment into the psychedelic sector is coming from, broken down into 2 parts. We have venture capital, which over the last several years has put $1.6 billion into the psychedelic field. And then we have this all other public financing, private placements and public offerings and the like at $2.4 billion into the psychedelic field. So $4 billion of capital in the sector to date over a long time. Now, some of that was before washouts, and much of it is not active anymore, but of course more comes back. So that's the left side is where it's coming from. On the right side, you have the sectors to which it is flowing, and this is really quite striking to me, and hopefully you all see the same thing. More than 80% of the capital coming into the sector is going to drug discovery and development, is what that small label says. To remind you, drug discovery is work in a laboratory to come up with a substance, a molecule that is a candidate to be a drug. Development is the progressive and increasingly complex testing of that substance to see if it can really be a drug. So 85% of the capital into the field to date has gone to drug discovery and development, with almost unmeasurably small amounts relative to that going to manufacturing, clinics and care delivery, and technologies. Now this is overall time. Psychedelic Alpha has helpfully also can cut it by time periods, and so I asked to compare what we have on the left here. This is the figure that I just showed. No change from that, but I've labeled the percentages for purpose of comparison. There's your $4 billion broken down in this way. in the last year, or since the beginning of 2023, so I guess a year and a quarter, we see a few shifts. There is it's less venture capital heavy, and that's what you'd expect. As an industry matures, you should need less from venture capital and more for public companies that, that have become more established. But what's also happened is that the focus on drug discovery and development has become even more extreme. I had thought the 85% was extreme and it might get less so, but it's actually gotten more extreme, with more than 95% of the capital into the field being toward drug discovery and development. And for anyone who's been working in this field, this should set off some alarms, because you can understand why drug discovery and development takes so much. I mean, it is extremely, extremely resource intensive. It costs a fortune to bring a new drug to market, especially when you bring in costs of failures. And it tends to be the area of healthcare that produces the greatest returns for investors, so capital flows to where you'd see the greatest returns. But anyone working in this field should be a little nervous about the lack of resource going particularly into clinics and care delivery. So where I'm going to turn next is saying a few words about a framework for thinking about what is needed in clinics and care delivery. And incidentally, I appreciate the pictures taking the pictures for this slide, but I promise this data is available from Psychedelic Alpha, and you can look and play with it and parse it any way you want. That was the laser pointer. So stepping back and thinking about care delivery for psychedelics, I go back to a general way of thinking about care delivery that has emerged in different sectors of healthcare over the last, well, I might say decades. Some people, I'm sure, will tell me it's 20 years, and then someone else will raise their hand and say it's been 30 or 50 or 60 years. But it's the idea of patient centricity in healthcare. And it relates to this issue that historically, in many healthcare sectors, a company or a provider, a hospital, what have you, would say, okay, here's our business. Now, what's everything that affects us? There's patients, there's providers, there's competitors, there's insurance companies, there's all these sort of entities that affect us, and we're going to design our strategy to deal with all of them. And it's become thought more and more by participants in the healthcare space that that is going to lead you to bad strategic decisions. And so there's at least some movement to recognize, okay, if we think about the patient's journey alone, if we think about the journey from the point of view of the patient and all of the different entities they will encounter, then we will make decisions that lead to better outcomes, to better safety, to better patient satisfaction, and to better engagement by patients on their own health beyond whatever therapy we're bringing. And it's led to me, and most of them work at BCG, have been to a lot of meetings where I've said, look, we're going to spend 80% of our time thinking about this end-to-end patient journey, completely irrespective of our client's role, and the last 20% on what it means for our client, instead of the other way around. And we need to be doing more of that in psychedelics as well. And when I try to break down the kinds of entities that a patient will encounter, and I know this is horribly crude, but I think of them in 4 categories. There's a provider of medicine. There's a payer that's going to cover that, hopefully going to cover that medicine and the care that goes along with it. There are the care providers themselves. And then in any area of medicine, what tends to emerge is a variety of services that often look very bespoke and very distinctive for that area. And that's going to end up being one of the most interesting parts of psychedelic care. Now, it's all nice to say we want to orchestrate this beautiful patient journey with all of these actors kind of working in concert together, but it is incredibly hard. And I'm gonna say a little bit about what is under each of those 4 pieces I just described to give a sense of the complexity. And I'd also like to give a sense, I have a bit of a thesis that for the ones on the left, you're going to see there's a lot that leaders can do to orchestrate good experiences for patients. But the areas on the right side are ones that are much, much harder to orchestrate and are going to be much more emergent. It's going to come much more from grassroots creativity to discover what kinds of things might help patients. And there's such decentralized sectors that there's really no way to orchestrate, but you'll hear about emergence quite a bit, I believe, over the next couple of days. So very briefly, I'm not going to dwell on this too much because this is going to get complicated, because the point is to show you the complexity. Getting medicine to a patient is not a drug company giving a patient a product, as you might get in other ways. And drug manufacturers don't have retail channels for their products. They sell them into wholesalers. The wholesalers in turn sell them to pharmacies. Pharmacies are a place where a patient can get a drug, in principle, in return for, sorry, I should have said the solid arrows are flow of money and the dotted arrows are flow of some product or service. So patient gets a drug from a pharmacy and pays some kind of a co-payment or co-insurance in most cases. That doesn't seem so bad, but from the point of view of a drug manufacturer, it's multiple layers to orchestrate that are a buffer between themselves and their end user. Anyone who's an entrepreneur who runs a business who imagines 2 extra intermediary layers between themselves and their end user probably finds that a little bit nerve-wracking. I'm going to go down to the payers and the insurance side. This one, I'm not going to go into the technicalities of it except to say they're severe. Most of us are probably aware that there's a thing called a health insurer, a health insurance company that most of us would have some relationship with. And those insurers collect premiums from patients, but in the case of pharmaceuticals, most insurers do not directly manage the insurance coverage of drugs. They outsource that to some to some organizations called pharmacy benefit managers that are basically, they're the outsourced providers specifically of services for reimbursement of drugs, and they care relentlessly about managing the utilization or access to drugs toward those who have the most demonstrable need at the lowest possible cost, which obviously is good for the system in some ways, but challenging in others. And so it is really when a pharmacy buys a drug from a wholesaler, dispenses it to a patient, it's this pharmacy benefit manager that pays the pharmacy back for that. But they'll only do that in most cases if the manufacturer pays a bit of a rebate back to that pharmacy benefit manager. If the manufacturer does not pay, they'll pay off the PBM won't pay the pharmacy won't stock the drug, et cetera, et cetera. So now it's getting harder and harder for the manufacturer to orchestrate these things. One other quick note on this. I want to point out the employer down here. Many of us have our insurance. It looks like we have an insurance company, but that insurance is actually funded by an employer. That's going to be really, really important in psychedelics because in almost every new area of health technology, the quote insurers, the back-end payer who pays for that care when it is new, the early adopters, the early experimenters are usually forward-thinking employers who see coverage of that new technology as a competitive advantage in their sort of battle for talent, in their workforce strategy. So we in the psychedelic field need to be exceptionally focused on value propositions to employers, and I believe you'll hear more of that from some innovators in that space today. I'm going to go over to care providers a little bit. I think it's obvious that providers are essential for this, but again, it's not just going to be, I think we already have tastes of this, it's not just going to be one doctor who takes care of all of this. There might be a fundamental specialist provider who works with that patient, but that provider, especially in the case of psychedelics, these long sessions, is supported by a care team and will need to continue to be supported by a care team just as much as a cancer patient is, or just as much as a patient with a severe autoimmune disease is. And similarly, most of us in this room might not have a direct relationship with a specialty provider for their need. We work from a primary care doctor who acts as the referrer. So now we got this problem of needing to orchestrate the ability to get from referrers to be aware of psychedelics, to refer to providers, for providers to have the right care team for this kind of care in place. I just said orchestrate, but I shouldn't have said it because this is too scattered and too fragmented to be orchestrated. But maybe there are things we can do and talk about in this conference to create conditions under which good systems like this can emerge. This will be emergent. And then the last one, and this one I'm going to keep, this one's going to be vague and murky because it is so different by specialty, by area of medicine. It is the various, quote, services that you see. There's one common element in a lot of services around pharmaceuticals called a hub provider, which I think we'll hear more about today. Lots of things come up where a patient has a question or a care provider has a question. Where do I find a specialist? What are the adverse events I should be aware of? How do I deal with the paperwork to get reimbursed? And manufacturers usually contract with and pay an organization called a hub provider to essentially act as a call center to take and deal with those kinds of questions. And that's going to be essential for any drug company working in here. After that, it gets much more scattered. You see PAGs, these are patient advocacy groups like the Alzheimer's Association or the American Cancer Society. You have a question, you need help, you want to be brought into a patient community with others like you. Patients often like to listen to other patients more than they like to listen to doctors. And so patient advocacy groups provide that service. But then I think there's this big unknown, these question marks. And you could spend hours speculating about what kinds of new services for patients in psychedelics we should expect to see emerge. And to think about how vast this could be. Think about everything you've ever heard about, quote, integration, different modes of integration, different ways of delivering integration, why, all the different reasons it's important, what do good or bad integration services look like. Integration is going to be a fundamental service that's not to be assumed to be provided by any of these others, and that is probably just a small part of what we should expect to be filling that box with a question mark. So I hope over the next couple of days we'll think about ideas for what kinds of services might need to emerge or might need to come into being, and what we can do to create conditions for that to be as easy or as streamlined or to make them as accessible as they can be. So that's a little bit of a picture of this nice idea about patient centricity. And yeah, we want a drug company, we want to put the patient at the center and understand their whole journey. But all of this stuff has to be put in place for it to work. And now I'm going to go through a few of these boxes and say a little bit about the state of play in some of these. And you'll see, like I said, some of the dislocations, some of which point to challenges or obstacles that have to be overcome. And some of them may point to business opportunities for those who can find ways to overcome them. And the first I'm going to talk about is medicine. I'm not going to go to wholesalers or pharmacies, but I want to say a little bit about the state of the drug pipeline, the funding of that pipeline, and some interpretation of what that means. So let's see, I didn't do this as a build, so there's a lot on the slide, so I will again ask you to bear with me. Let me orient you to the slide, and let me first say, when you think about a pipeline of drugs, you think about a couple of phases, and those are listed across the top, from the middle to the right. New drugs go through first a range of preclinical development. Whenever you say clinical development, that means testing in humans. So preclinical means not testing, not yet in humans. So preclinical development, then it goes to these phase 1 and phase 2 studies. Those are kind of exploratory studies in small numbers of subjects to see if the drug really does anything at all that's worthwhile. And then you get to phase 3 studies. These are big registrational studies designed to acquire the data to allow you to seek approval from a regulatory authority like the FDA. A new drug application is how you submit that data to request that approval. And so you have a pipeline that looks at, like, okay, what are the compounds and the conditions that are in different stages here? And the top half of these numbers refer to the number of compounds or compound indication combos that you see in the psychedelic space in particular. And we separated psilocybin from non-psilocybin. And I have a big apology, actually. This slide was prepared a little while ago. It is, sorry, I shouldn't apologize on someone else's behalf. It is, again, from Psychedelic Alpha. Thank you, Psychedelic Alpha, for the Psychedelics Drug Development Tracker. But I pulled this when it was out of date, and since then, one more psilocybin-based approach has moved from phase 2 into phase 3, so that should be a 2 in the upper right. Congratulations to the USONA Institute on crossing that threshold. So we still see, like, the late stage is still pretty lean, but we have exciting stuff ahead. This exploratory stage is enormous. 50 products for psychedelic approaches, 50 potential products for psychedelic approaches to psychiatric conditions is extraordinary, given the moribund state of neuropsychiatric research in the pharma industry 10 years ago. There's a problem, though, which is that the pipeline to develop these is about $2 to $3 billion underfunded. And we get that by saying, okay, how much capital does it have today? And then compare that to what are the typical costs to develop a drug from preclinical, from phase 1 and 2, all the way through to the end, with standard assumptions about how much each phase cost and what are the attrition rates, the fallout rates, et cetera. You model that out, you find a $2 to $3 billion shortfall. Now, of course, as these progress, capital will come in, but the most likely place to find that missing $2 to $3 billion is the mainstream pharma industry. But the mainstream pharma industry is not sitting there thinking, okay, I want to figure out how to deploy my dollars into psychedelics. They're thinking, how do I want to deploy my dollars into neuropsychiatry generally? And for that, the psychedelic companies are competing for that capital with all of the other neuropsych approaches described at the bottom that have many more mature candidates ready to go in phase 3, still have a very robust phase 2, and have plenty early as well. So this is going to leave us with this question that I'll mention and recap at the end. Where's the $2 to $3 billion going to come from? And how is it going to compete with non-psychedelic approaches? Are we going to be able to generate the data about the psychedelic approaches that is compelling enough to divert the flow of capital from more traditional methods to these? That's going to be important in the psychedelic industry. The next one I want to turn to, I'm almost embarrassed to show the data because it's such a well-known problem on the provider side, which is the workforce shortage. And I want to give you a feel for what that shortage looks like and what could drive it to be worse. And so here we have a couple of professions. We have adult psychiatrists, mental health and substance use social workers, mental health counselors, and other psychologists. A huge apology that I do not have nurses on this page, and I would acknowledge the essential role of nurses in the psychedelic world. I struggled to find data to cut it to get the right nurse portion. That's a terrible excuse. But the specifics of these numbers are not what's important, and I'm happy to talk to anyone in that field who can help me dimensionalize the shortage of the relevant types of nurses for psychedelics. But now let me say a word about what the data we're showing about each of them is. I'll take the smallest one. I'll take the adult psychiatrists. This year, or say last year, these are in thousands of individuals. So we had 36,000 practicing adult psychiatrists in the United States. Much of my work is US-centric, so I should at least acknowledge that. 36,000 in the United States. A shortage of 12,000 relative to the actual active demand, people seeking support from an adult psychiatrist. A 25% shortage in a service industry is really crazy. You don't see that in most other service industries outside of healthcare, but you see it all over healthcare. This is not just a mental health problem. This is most sectors of healthcare have this issue. And then you project forward to 2030, and you know, HRSA is the source for this kind of data, and the analysis is as robust as you can get. Fast forward to 2030, in this case, the number of adult psychiatrists is actually expected to drop. Retirements are outpacing the pipeline of new psychiatrists. Demand will grow, so that pink segment will go from 12 to about another 28,000. So that shortage will get worse, but there's an even bigger problem. This dotted line that I've labeled as, quote, real demand as opposed to the active demand, we say, what happens if we are successful with our efforts to improve insurance coverage for mental and behavioral health? Well, that's more demand and a more severe shortage. What happens if we are successful in bringing about equity of access and equity of utilization, racial and ethnic equity and geographic equity, where it's well known people in rural areas seek mental health care much less than people in urban areas? If we actually resolve that inequity, then the shortage is going, which of course we want to do, we hope to do that, but it is going to exacerbate this shortage enormously. And this occurs across all of these verticals, and of course nurses as well. So to me, this points to a big problem for the psychedelic field, and also a big opportunity for those who can figure out how to have the individuals and the professionals we do have do their best work, spend the most of their time on what only they can do, and delegate the work, the busy work, the paperwork, the stuff that is not the full professional capacity down to, you know, a lower level of professional. I see I'm running short on time, so I'm going to briefly touch on one more, and then I'll go to a few recap questions. The last one I want to reference is about the insurance industry, and I cannot give a whole primer on that. You're going to hear a lot about that later. But what I want to point out to you is a double whammy problem in the insurance industry. So the first problem with insurance coverage for psychedelic therapy comes purely from drug reimbursement. And obviously, I'm not going to take you through all this data, but this is a look at how the big 5 insurers guide their PBMs, their outsourced agents, to cover a variety of psychiatric drugs. Many of them are old, but a few of them that you see at the bottom are newer. And I'm not going to take you through the whole legend, but suffice to say, red is bad and green is good in terms of the generosity of that coverage. And what we find is that for most of these, there are what we call very, very strong utilization controls. Utilization controls is the insurance company's word for restrictions on who can get a drug, regardless of a physician's view of who should get the drug. And we see in particular at the bottom, we see Spravato there, you see a lot of purple, this very select coverage. And so we're going to have this situation as these therapies launch that we expect insurers to be very selective about who they will reimburse for. And that's for the drug. The drug side is relatively understood. The industry has a pretty good understanding of what evidence needs to be brought to gradually open that wedge and expand access. But a much bigger problem is waiting that most drug companies don't have to deal with, which is reimbursement for providers, for the hours and hours of preparatory medicine and integration time that's needed from providers. And I thought, I saw a report come out recently from the Research Triangle Institute, funded by the Bowman Family Foundation, which showed really striking data about the extent to which reimbursement for mental and behavioral health professionals lags reimbursement for medical and surgical professionals, for medical doctors, essentially. And they took a really interesting angle to it. And I'm sorry, this data doesn't speak for itself till I tell you this. All of you, suppose you've got your insurance and you live in Chicago like I do, and you want to go see a specialist. Some specialists in Chicago are in-network, and some are out-of-network. If I go to an in-network, my insurance might pay most, might even pay all of my cost. But if I go out-of-network, insurance will pay very little of my cost or possibly none of it. And so the RTI, the writers of this report, said, well, let's look at how often people go out of network. People have to go out of network and pay a much larger share of their cost in mental and behavioral health versus in medical and surgical health. And what they find is that for behavioral health clinicians, people go out of network not like 30% more often, but 3.5 times more often. They go out of network for a psychiatrist, an MD professional, 9 times more often than they go out of network for other kinds of medical doctors. This tells you that the insurance companies have not been doing all that they can, have not been doing nearly enough to build the networks of clinicians. And so when you or your patient goes to seek psychedelic therapy, they're going to have a very difficult time finding one who insurance companies to sign up to be in network and therefore have committed to paying many of those costs. So that's another major dislocation. It's a major friction patients are going to face unless we work through that in the coming years. Again, think starting with employers and then working toward large insurance companies. So I hope that's given you some taste of some of the issues that you'll see addressed directly or obliquely in the next couple of days. I do want to leave you with a recap of a few of these questions, and they are a recap. But the first is a reminder: an incredibly rich drug pipeline. One that, remember, my friend David called me in the mid-2010s, and I made him repeat 3 times what was happening at MAPS. If you told me there was going to be a pipeline, I would have really been floored. But with a real shortage of funding, where is it going to come from? Can it come from the psychedelic field? Does it have to come from mainstream pharma? And what are the implications of trying to get it from mainstream pharma, given all those other things they can invest in? The second is we got this opportunity to build not to build a brand new health system, but to build a new wing of our health system with real patient-centered care, but enabling the emergence of models that overcome the failures of today's mental health system is not obvious at all, and I expect the creativity of this group will be seen over the course of today and the next few days. And then finally, the economic case to pay for psychedelic-assisted care, assuming the science lives up to expectations, is enormous. It's that $1 trillion from the beginning of what I shared. But to evolve the insurance and reimbursement systems to be able to ensure access to both pay for the drug and pay for the therapy in one unified payment, it requires enormous change within the insurance industry, and we have a lot of work to do to try to help them evolve those systems. Thanks for listening. That's what I wanted to share with you. Happy to discuss this one-on-one with anyone who's interested. Thanks.